Muito boa noite a todos. Bem-vindos a mais um webinar COVID-19 organizado pela Sociedade Portuguesa de Pneumologia. Hoje vamos ter aqui um distinto palestrante que trabalha em Madrid, onde está a acontecer muita coisa nesta patologia, nesta pandemia, e portanto penso que vamos ter uma sessão muito útil. Lições que vamos aprender para podermos poder implementar aqui no nosso país. Eu tenho comigo três pessoas de elevada craveira nesta área dos cuidados de ventilação, quer invasiva, quer não invasiva. A doutora Susana Moreira trabalha no Hospital de Santa Maria. O professor Miguel Gonçalves trabalha no Centro Hospitalar de São João, na Faculdade de Medicina, e vão estar comigo no fim da sessão do Dr. Javier Sayas para fazermos algumas perguntas. Eu penso que temos também algumas perguntas que já recebemos, portanto, o que mostra o interesse que este tema tem e daquilo que nós queremos todos aprender. Para que seja também possível que os nossos ouvintes anglófonos possam entender a nossa sessão, e penso que ninguém se vai incomodar por falarmos em inglês, até para, enfim, não tentarmos falar um portunhol ou um espanholês, vamos todos falar inglês para conseguirmos ter aqui uma audiência ainda mais alargada. So I will start again, and I cannot thank you enough, Javier. So it's really, really a great honor for us to have you here tonight, and we are really looking forward to your incredible experience in these hard times in Madrid. Madrid is right now the epicenter of the pandemic in Spain. And I know that you have had a hard time these days, so I really thank you so much for your time. Before I hand over to you and just tell you that Dr. Sayas is the head of the mechanical ventilation unit of the pulmonology department of 12 de Octubre Hospital. He started with a few intermediate care unit beds, and now he's the head of 20 beds, so it's really a huge burden for him, and I'm sure that all his team will tell us a lot to learn and some messages to take home. But just to introduce a little bit the topic, I have a couple of slides that I'm going to share with you. So this is the first page of Lancet tomorrow, really showing the anxiety and all the stress that is happening also in the UK. So we are talking of the situation in the Latin countries, and so especially coming from Madrid, we are looking forward to see the experience. But what is showing in the UK literature, especially this first page, the front page of Lancet, really shows us how much anxiety and all the concern that the people from the UK are also having. So it's not a problem of lockdown, it's really an enormous surge in the hospital and all in the NHS. And this is what we are currently seeing in the worldwide. So really very recently, the US has gone up to the first, the ranking, really after China. So China is not having a lot of cases, as you know. So Italy is still number 3 and Spain number 4. So these are the top 4. We in Portugal, we stand on the 14th place. And if we follow the trends of the countries that I mentioned, as you can see, if you look at the Spanish trends, so they started earlier than we have, and so we are expecting that in 2, maybe 1.5 weeks, we can reach their numbers, and I think we have to be very well prepared. This is what are our numbers. So we are reaching right now for today 4,268 cases, and this is the exponential growth. As you can see, we are still increasing. And I think that coming back to the problem in the US, I think the US reaches us in Europe maybe more strongly than China. So I think that a good lesson is New York, because they are really having an enormous problem, the problem that you in Madrid have already experienced. There are a lack of ICU beds, a lack of ventilators. As Governor Cuomo was saying, they had 3,000 ICU beds, and they needed, according to their forecast, 53,000 beds. And this is what is happening. So they have already a lot of patients in the ICU, so 23% of hospitalizations. And so that's what he is facing. So a lot of hospitalizations, a lot of ICU, and a few ventilators. However, the governments, and this seems to be happening across the world, they are just sleeping, and they are not, getting the right directions, the right decisions. So apparently, Trump is also doubtful about his predictions. I hope he is wrong, but I think Governor Cuomo is giving us, everybody, a good insight in what is going to happen. And of course, we have to think about the worst case scenario, and worst case scenarios can be this ones. So one patient or two patients sharing a ventilator. So I think that the ventilator issue, as we have heard a lot of talks, but we need really to understand what is our stockpile, and to urgently establish policies inside the hospitals to allocate these resources. This is some very interesting viewpoint recently published in the JAMA about the critical care beds and the ICUs. Another thing that I think we should be preparing for, and this is again a recent paper published yesterday in JAMA, is that what is going to happen to our units, to our hospitals after this surge. So the post-acute care of COVID-19 is going to be a huge burden, both for the hospitals, but also for the rehabilitation facilities. So we have to take care. We have to think ahead, like this author is talking. And I think that also we need to understand a little bit better how we are dealing with this new COVID-19 ARDS. I think that respiratory failure in the context of COVID-19 has given us a lot of different challenges. And I think this very interesting viewpoint from Luciano Gattinoni and John Marini, very recently published in the intensive care, is really giving us a little bit of insight on how we should take care of this patient. And I think the message that is saying that less is more can be an interesting way of dealing with this. Maybe we can talk about this in the discussion. And so now I would hand over to Dr. Javier Sayas, that is going to tell us a little bit more about the lessons that we can take from the Madrid experience.
Thank you very much, João. Okay, can you hear me?
Yes.
Can you see the slides?
Yes.
Let me start here. Okay, we have prepared just a very simple presentation. I had no time in my current day activity to go in a more detailed data analysis or something like that, but just to give you some insights of what you may expect of what is going to happen. I hope it does not, but you may be prepared for the worst and hoping the best. No? So just to see what's happening right now, this is from today's newspaper. We are preparing the second mortuary to allocate all the bodies that cannot be handled in the hospitals, morgues or something like that. And we have one huge ice skating board, and it's not going to be enough to allocate all the bodies from these deaths. And even the army is collaborating in transporting the bodies, moving the bodies from the hospital. So it is not. You may say it is not a flu, a current flu or epidemic flu. It's very severe thing. You can see here how we are dealing with increasing the slope very marked through the 20th week before. Sorry, after the case number 100, and this exponential increase may collapse any medical system, and that's I think the key point of what is happening here. It's a huge amount of cases in a very short time frame that may need intensive care, and they may occupy a bed in the intensive care unit for more than 20 or 25 or even 1 month. So it is going to collapse all your resources. Also the deaths, you can see here how an extreme increase in deaths, almost duplicating the deaths over 2 days. In each days, you can see how the deaths will duplicate here in Madrid. Other provinces are moving just quite slowly, but I think they will find also a huge increase in the next days. The 7th of March, I talked with Stefano Nava, and he wrote me an email, and I cannot believe what he was talking about apocalypse now, gastroenterologists, neurologists setting people on CPAP with just 2 hours training, no guidelines, only some scarce evidence-based medicine for pronation and ECMO, and how all the ICU beds were gone in North Italy. And I could not believe that was going to happen to us. We were talking of some of these news in the last days of February, where we met with João in Paris, but I did not realize that was coming to Spain. Anyway, we tried to prepare for that, and Stefano talked about the use of CPAP better than NIV with 50% of success, and how the patients were intubated, sometimes in the ward, and they stay in the ward just to wait for a free slot in the ICU. Okay, so we have our first severe case was a 40-year-old pregnant lady that had preeclampsia and went a cesarean, and in the postoperative period, he presented a severe distress syndrome. Well, she was admitted to the ICU the 29th of February. She's still at my ward with tracheostomy in the weaning period, and we are having to connect her for more than 12 hours a day, performing almost daily bronchoscopy to clean up secretions. So just to give you a figure of what is the timeline of these patients when they are admitted to the ICU. Almost a month there, and severe sequela in their lungs. Okay, so through the first week, we increased from 15 patients one day, the next day 25 patients, the next day 40 patients. At the end of the first week, we had 100 patients. So we could manage an initial structure in the emergency room with separate rooms for testing, separate for suspicious cases and confirmed cases. We had a clean area, and all of the personnel had full protective equipment. And most patients were elderly, comorbid, and some of them from different socio-sanitary facilities. But now we have really young patients, 40s, 50s. I have just admitted a boy that was one of my schoolmates, and they are really severely ill. And it has changed completely the frame of the kind of patients we are now attending. Also, we have a very elderly ones, but they will die within 1 week or less. But these young patients, they do. They may have a very slow course, but finally they get really severely ill. Okay, so 1 month later, right now, of the 1,200 beds we have in the hospital, more than 1,000 are exclusively dedicated to COVID-19 patients. Pediatric hospital is dedicated only for clean adult medicine. Almost pediatric activity has been reduced barely to zero. Ambulatory surgery unit has been converted in another clean ICU, and all the ICUs in the hospital have been dedicated to this epidemic. ICU beds have risen from 32 to barely 70, and we still lack ICU beds. And ICU and anesthesia have mixed in one team, and we have built teams with pediatricians, thoracic surgeons, urologists, or whatever doctors we are able to join to our teams. If you see, this is our hospital. This is the general hospital with 1,000 beds here. This is the pediatric and gynecological building, and this is the outpatient building. Well, this whole building is exclusively dedicated to COVID-19 patients. 3 wards of this hospital is also dedicated to these patients, and we have to convert some facilities we have here to clean patients. We still have acute myocardial infarctions or some trauma, although it has decreased quite a lot because of the confinement, but we still have to attend clean patients. Well, just a few insights of what we are doing with the ventilatory support. At the beginning of this, we have pretty clear that when the patient have a severe hypoxemia, we prefer to go directly to invasive ventilation. We knew that playing around with high flow or with CPAP or NIV may delay an intubation, and that may be potentially may impair the outcome of the patient. And that was possible through the first 2 weeks. As the ICU get collapsed, we experience an increase in the criteria to be admitted to the ICU, and suddenly the age dropped from 80 to 75, then to 70, then to 65, and even to 60 without severe comorbidities. And there is no room for patients with transplant of any kind, with COPD of any kind or any severity, with renal failure, but even a suspicion of, for example, COPD without any spirometric data was assumed that he was not able to be admitted in the ICU. So we had to implement some non-invasive support in the respiratory intermediate care unit. Well, almost all of the respiratory failures are hypoxemic, although we have some 3 hypercapnic failures that were successfully managed, 2 of them with NIV, and they are ready to be discharged. And according to the Italian experience, as Stefano Nava told us, they have mild compliance impairment, but they have severe hypoxemia. So they have a very severe shunt. So we prefer CPAP modes. And as they have very high drive and they may harm themselves, they may have patient self-inflicted lung injury, we consider also in all of these patients to use continuous morphine infusion to moderate that high drive. We are not in the ICU, so we are not using propofol or other drugs like that, but we found morphine to be quite useful. And another issue was nutrition. In most severe cases, we place a central line and use parenteral feeding, but in some cases, we thought about using nasogastric tubes, but that may increase dispersion of particles that may harm all the healthcare workers. So we advise to be cautious with that kind of nutrition. And as the epidemic progress, we have to recruit neurologists, surgeons, endocrinologists that are in COVID teams. So we had to use simple peel CPAPs to be used outside the respiratory ward. And we have now CPAPs through all of the hospital, and sometimes they are being set up by endocrinologist or a pediatric physician. In the respiratory intermediate care unit, we prefer to use whatever ventilators we have. These patients have a very high peak inspiratory flow due to its high drive. So sometimes the CPAP is not able to compensate for that. But if you are using a ventilator, it will do. And we are using Astral or Trilogy Evos. As Stefano told us, we thought that also the helmet will be the interface of choice because of the safety for the personnel, but we found no helmets available in the market. All were hijacked by the Italian government, but recently we have five units. We are starting to play also with the scuba mask. You may see them on Twitter and everywhere. And I hope through the next days we will have some more experience. But for now, as we were quite fast to buy some masks and filters, and we have still some masks to I think to cover this next week. Don't know what is going to happen after this next week in terms of different supplies. We use filters in all of the circuits. You can attach them to the outlet port or to the respiratory valve port. Some of them, they are not able to work quite well due to increasing resistance. Also the Trilogy. I'm hearing myself with some return. Can you turn off the microphone? Miguel, I think it's you who has. Okay, thank you. We are also using Astral ventilators in double circuit, and we were able to buy one of the few Trilogy was remaining in the market, and we are using also them in invasive and non-invasive ventilation. Although Philips does not recommend it, but we checked that it may work okay using a two-filter system. But what has saved us a lot of patients are very simple PEEP valve CPAPs, like this one pulmodine, using a filter between the mask and the PEEP valve in order to avoid particle dispersion and to increase security for the personnel. And for patients, we have to set up on leak ventilation. We use a filter between the mask. We will prefer to use the blue elbows, but we have run out of them also. So we use these white ones with anti-asphyxia valve, and then the filter, and then the leak. In this situation, we do not mind about the possibility of rebreathing. We just increase CPAP and hope it does not rebreathe quite a lot. For the first 40 CPAPs, we set up on 3 NIV since the beginning of this outbreak. Our perception was really worse than what the figures tell us. And by now, we have almost 60% of the patients in who we set up a CPAP alive, and even 2 have been discharged. We use this non-invasive support when the patient is not able to achieve an oxygen saturation over 92% while breathing in a non-rebreathing reservoir mask. But we only consider this non-invasive support if it is a bridge to something, not as a bridge to death, but a bridge to get a free ICU slot for being intubated, or if we are using anti-inflammatory treatments such as tocilizumab to wait to see if it is effective. For example, this is a 38-year-old male with end-stage renal disease under peritoneal dialysis that was not accepted to the ICU only because he was on dialysis. And our nephrologist called us, and we found that that patient with 88% of oxygen saturation under reservoir non-rebreathing mask. And he was accepted also for tocilizumab therapy. We have a very restricted use of this drug, but we need to find to buy some time to see if it was useful, that therapy. So we start on CPAP on 15 centimeters of water and 0.9 FiO2. So the oxygen saturation increased to 94%, and he has responded quite well. So now it's ready to be placed on nasal prongs at 2 liters per minute. And we hope we will be able to discharge this patient. You can see also how the CRP dropped dramatically when tocilizumab was started. In some patients, we need to use prone position as in the ICU, but these are non-sedated patients. They are conscious, so we ask them to self-pronate. This is a lady that a photo that I have taken just this evening, and she has learned that she has to stay 2 hours in the prone position, 2 hours in a lateral decubitus, and it's the only way to increase her SpO2 over 92%. Other colleagues are rescuing all devices, such as this CPAP high flow from Drager, or using the scuba mask. We are ready to play with them, but not needed for the moment. Other hospitals are starting to use them because they have run out of masks, helmets, or whatever they can use to ventilate the patients. And just one idea on how to manage barely 1,000 patients with high risk for respiratory failure. It's very, very difficult to find what patient is worth to be put on an IV or to fighting a free ICU bed. So we managed to create an alert system with respiratory rate, arterial pressure, SpO2, oxygen, FiO2, D-dimer value, and that generates an alert based on the respiratory risk, and you can see it in the clinical record. You see here an alert. This is the respiratory intermediate care unit, so you can see that almost all of the patients have a respiratory alert, and they are both automatic or as a physician you can mark the patient who may have high respiratory risk, and you can also mark the patient that is not suitable even for non-invasive support due to age or comorbidities or something like that. You can see here a lot of different alerts you can set up. For example, no candidate to mechanical ventilation, so you won't have to set up special measures, special monitoring for that kind of patients. And yes, I'm finishing just two last advices. Mind your oxygen supplies for the hospital. Expect an increase from 200 to 400 demands on the oxygen is needed. We are the truck that replenish the oxygen storage. It's coming 2 times per day to the hospital. And take care of yourself. Almost 15% of our colleagues are out of play as being infected. Even currently, our head of the department is admitted with respiratory failure in our beds. And take care when you are performing high-risk procedures such as bronchoscopy or NIV or physiotherapy, and ensure protection for all of you while you can and while you have enough protective equipment.
So good evening, everyone. Thank you so much to take this time to talk to us. We have so many questions to ask, so I'm going to start. One of my first thoughts is, what ratio of doctors and nurses do you have for your beds?
In the respiratory intermediate care unit, we have increased the nurse to patient ratio up to 4 nurses per 1 patient. Sometimes we are even more like 3 to 1, but most of the time it's 4 to 1. And for doctors, well, it depends. Currently, I'm carrying the 20 beds by myself with a team of 1 thoracic surgeon, 1 respiratory pediatric physician, 1. Sometimes we even have respiratory resident, but we are trying to set teams that are coordinated by a senior pulmonologist, and then different doctors from all of the specialties available in the hospital.
And do you have negative pressure in all your rooms? How do you handle that?
At the starting of before everything of this insane epidemic, we only had 2 beds that were used for tuberculosis, and we are not using even those beds because we have patients all over the hospital. So no, we are not currently using any negative pressure beds.
So now I would like to introduce also from the team of Javier Sayas from the 12 de Octubre Hospital, Dr. Ana Hernandez, that is also a pulmonologist, and she's also very highly involved with the care of these patients. So go ahead, Ana.
Yes. According to your question of negative pressure rooms, yeah, we don't have that. That's a luxury that we don't have. And we also have no open spaces for ventilating. So we are very careful for the double filter in the equipment. We are not using things that we can't filter, because I think the most important thing, even more than equipment, is personal assistance. I mean, if these patients have no nurses and no doctors, they are lost. So we are very focused on protect ourselves so we are not sick. like patients.
So maybe Miguel, you can go ahead with some more questions.
Yes, thank you to the Portuguese Society of Pulmonology, and thank you, Professor Winck, for the kind invitation. Congratulations to the Portuguese Society for putting on these webinars that are so clear and helping so many teams around the country. So it's really a good initiative from the Society. I have no words to express my gratitude to Javier and Ana for taking the time to share with us our experience. Our solidarity is with nuestros hermanos in Spain, and we are preparing for what is coming and listening to your chaotic experience, giving us time and giving us some very good advice to prepare. The question, well, I'm working on the organization of the teams and some specific technical issues of my hospital. At the moment, we are the hospital that has the most admitted patients with COVID-19. We have almost 200 patients in the hospital, a great number of patients in the ICU. And one of the concerns, and you started with this, Javier, was the importance of the staff training. Now, we know there will not be enough critical care doctors. We know that there will not be enough pulmonologists or experienced staff. And we need to train other medical professions and the medical specialities, surgeons. So do you have any training program in your hospital where people can come and train and learn how to do a CPAP, learn how to put NIV? Do you have some kind of training options for these people? Because I can imagine that it should be very frightening for them to see these very severe patients and without any specific training.
Okay. Well, first of all, we did not have time to set any training program, so we decided to train by practice. I mean, the idea beneath setting up teams with a senior pulmonologist and then 3 or 4 physicians from other specialties that may control up to 20 patients, for example, it leads us to a system that they are being taught as they practice, as they attend those patients. The highest burden of patients are taken care by internal medicine. They have the highest amount of patients, but they send us the sickest patients in order to monitor or set up on CPAP. So setting those teams will train those other physicians in setting up quite easily a CPAP. We also choose CPAP with non-mechanic CPAP, such as Busignacs or those PEEP valves, in order to search for simplicity for those patients. What is more difficult to train our nurses? We have been recruiting nurses from everywhere, and they have a lot of shifts, and sometimes they are not the same through those different shifts. So it's quite difficult to have a good training for nurses. So when we find a patient that may need special care and may not be admitted to the ICU, we try to transfer it as soon as possible to the intermediate care unit. And we have seen really differences between our nurses there and outside our respiratory ICU. But I have to say that also in some other departments, and Anna has a lot of experience treating patients there, such as nephrology, they have been self-trained on CPAP use, and it's really easy to put patients there. So it's quite heterogeneous between different wards and different staffs.
Javier, I've been studying this a lot and in contact with Italian friends, and also now looking at your experience. Of what we are seeing is the system collapses because there's too much severe acute hypoxemic respiratory failure patients that need immediate intubation, and there's not enough ICU beds to take them. So there's a line of waiting, patients going in ICU. So I'm looking at strategies to facilitate the line coming in, so more patients getting in and more patients getting out. So we really need is a good step-up unit, so a good intermediate care unit that can hold these patients. And that's one of my questions, because people are very afraid to insist on NIV or CPAP, because every guideline says that if the patient is not good at 30 minutes or 1 hour, the patient will not survive, and that's not true. The more you get experience with CPAP at NIV, maybe you can hold the patient to get inside the ICU. So you need good experienced staff on the step-up unit, a step-up, but then you also need staff on a step-down, because these patients, they are 3 weeks intubated, they are sedated, they have ICU-acquired myopathy. Most of them, as you showed, have difficulty weaning problems. So is there any possibility, or do you have any advice to create also a step-down so that these patients can be discharged early from the ICU and be weaned outside the ICU? And I was talking to some friends in London, and many of them are getting tracheostomy precociously, so they can facilitate weaning, and then they have a step-down weaning unit to facilitate this rotation, more patients getting out and more patients getting in. What's your thoughts about this?
Absolutely. I mean, I know we are going to change the kind of patients. We are going to change as the timeline of the epidemic goes on. We are preparing to change from step up and monitoring and trying to hold those patients in order to get intubated. We all know that delaying the intubation may impair the prognosis, but sometimes you don't have a choice, like in these cases. So and I think it's better to have the patient with 94% SpO2 on CPAP than with 88% on face mask, waiting for the ICU bed. But sure, we are trying to prepare to receive all those patients that they are also being tracheostomized, and we are starting to admit those ones. But you may also take in account that they are also going to stay a long time in the step-down unit. It's not only a problem of a long time in the ICU, but also a long time in the step-down unit that may compete with the beds as step-up unit.
So maybe a step down unit out of the hospital, like a rehab center where you have dedicated physiotherapists that can rehabilitate the patient, try to put the patient better, because it's really is cured of the disease. He has no infection, so maybe an outside system can be the solution.
Absolutely, but there is no Remio-like centers in Madrid or something like that, even though we have tried to set up many times, but currently they are not. So we have to act also as a step-down unit.
Yeah, I just wanted to add a few things. The teams, Javier told you, but the teams should be with a pulmonologist and then other specialities, and as diverse as you can, because maybe you will get sick, and it is good for other doctors to know what you're doing. We work, Javier stays in the ICU in the more severe patients, and I'm with the phone outside of the pulmonology ward and through all the hospital. And I also try to train the nurses that are in this unit. With this CPAP, this pulmodine CPAP, it is very easy to teach. They don't really have to set up the PEEP valve. I mean, you can set all of that, the PEEP and the FIO, and they can keep the management of the patient by just regulating the oxygen in the oxygen source of the wall, and it's very easy for them to learn. We have also performed a series of videos, that's very simple videos, and we try to I mean, we use WhatsApp. I know it's not very professional, but we do. And I think that's the most important thing.
Okay, maybe Susana, maybe you have more questions now?
Yeah, yes, I have. When you have these wake patients and you have to stop and feed them, how do you do? With oxygen, with high flow? Do they change the mask themselves with orders from outside? Do you go in the room? So the practical things that even with proning, how do you tell patients to prone? Do you have to go inside the room? How do you do it?
Can I speak? Yeah. Okay. We are talking about not really old patients. I mean, we have patients in their 70s or their 75s that they are not admitted to the ICU because some mild comorbidities, and so although they have a very low SpO2, they do not have a very high dyspnea feeling. So they are able to move, and sometimes it's as easy as telling the patient to turn himself in the bed, and it's really easy in that way. We are not performing prone maneuvers such as in the intubated patient with pseudo relaxation, and it's easier to tell the patient just to turn himself in the bed. About feeding, that's a key question. In those most severe that we are planning to have them on CPAP for 10 days, almost continuously, I prefer to pick a central line and put them on parenteral feeding. We have tried in one patient with nasogastric tube for feeding, but we feel it was a high amount of leak that make us feel unsafe about the dispersion of droplets. But most of the patients will tolerate just very few seconds of mass disconnecting to have kind of nutritional preparers, nutritional solutions that may have high concentrated elements for nutrition, and it's easy for them to sip them from the bottle for 2 minutes, for example, through a reservoir mask, for example. We do not use high flow because, as with our Italian colleagues, we did not find it to be as good as in other hypoxemic failures. And on the other hand, we feel it as potentially dangerous for all the nurses and so on. But we get into the rooms and we help them to eat, or the nurse is always there to help them to eat or try to drink some water or something like that.
Some more questions, Susana? I have a couple of them as well, but
I'm just have another one, so I'm finished now, in a few minutes. It's that one of your slides you showed that you were doing target therapy. So what drugs are you using, and how soon do you start?
So sorry, Susana, you're talking about tocilizumab or?
or any therapy besides support therapy?
From the beginning of the outbreak, we have changed at least 5-6 times the therapy protocol in the hospital. So it's crazy. It's never been so easy to get published in New England or in Lancet or any randomized trial with only 200 patients will be admitted without any critic. So it's really hard to find good quality of evidence to treat. So we started using lopinavir, ritonavir, and we dropped from that. We almost use commonly hydroxychloroquine for all the patients, sometimes combined with azithromycin, but we have found some serious adverse effects on cardiac rhythm. So we try to monitor QT distance. And in patients with a very high degree of inflammation measured by CRP and interleukin-6, we are trying to start with tocilizumab as soon as possible, as soon as we detect that there is a high increase in inflammation. The problem with tocilizumab is we have very few doses for each day. So there is a committee that decides to who is going to be give the drug and to who is not going to be given. In our experience with some very selected patients, around 10 or more in pulmonology, but around 40 in all the hospital. In our experience, in those patients that drop in the next 24 hours the CRP, as I show you in one slide, in those patients, we are able to run fast, dropping the oxygen needed, and they will tolerate to be disconnected soon in the next 2 or 3 days. You can see dramatically improvements, but we are not able to predict which patient is going to benefit from that. And there is also controversy in the use of corticosteroids. Some groups they are using when we saw a very high degree of inflammation and the patient is not suitable to be treated with tocilizumab, we may try a short course of corticosteroids.
Yes, I mean, if you don't, you have to see the two-dimensional problem. If you treat the hypoxemia, but you don't treat the inflammation, it's going to be useless. I mean, we try to support the patient and keep them above 90% oxygen saturation, but while we are giving some inflammatory, whatever, tocilizumab, if it's possible, but if not, steroids, because if we don't, then you don't gonna get results only by oxygen support.
You are using, in that cases, you're using CPAP or NIV as a bridge to nothing, as a bridge to death, not as a bridge to the ICU or to resolve inflammation.
Okay, Javier, it's perfectly clear that high-flow nasal cannula is not the first option, and CPAP is with high percentage of oxygen is also one of the first options. And of course, you were clear to say how is important to avoid patient self-inflicted lung injury. So with low CPAP levels and try to monitor the drive of the patient. So one of the questions I have is, what do you look at when you monitor that high drive? Are you looking at respiratory rates? I know you're using ventilators. So are you looking at the tidal volume? These patients with the increase of drive, they increase a lot their tidal volumes. Are you trying to give sedation and morphine to reduce both, reduce respiratory rates and reduce volume, because morphine is a drug that will reduce the rate but will maintain the volume. And the patient with volume also can have self-inflicted lung injury. So what are your thoughts about that?
Absolutely agree with that, and it will be perfect to sedate them with propofol, but we are not in the ICU. We are using it in very different environments. So although morphine decreases respiratory rate, but not tidal volume, it's what we can use in our practice. It's not perfect, I know, but I have to balance between security and what we have. So we prefer to use morphine. And for monitoring, we use respiratory rate. When using ventilators in our intermediate care unit, another interesting thing that goes ahead with the tidal volume is to see how the patient may be able to decrease the pressure of CPAP to a very high amount. So it also depends what kind of ventilator you are using. There are patients that with a low performance turbine, they will be able to depressurize the mask almost completely to zero. So in that cases, we may increase also the morphine dosage.
Do you have like a percentage of patients that have no criteria for intubation, but you give them NIV CPAP? Do you have a percentage of the patients that survive? Because it's a bridge from death, but can it also be, is there a hope that these patients can survive?
When we started with that kind of patient, we all feel very discouraged because we have a very high death rate. But looking at the raw figure that Anna gave me, and I tried to show you in the slides, we found that we were able to maintain alive till now almost 60%. Some of them will die in the next day, sure, but if we are able to achieve a 30 to 40 or 50% of success, in this kind of respiratory failure, for me, it will be a complete success. I'm sorry, I'm not talking about 80% or 90%, but this is the truth. The truth we are facing.
With the current situation, I think your thoughts are a breath of fresh air and gives us some hope that maybe when the patient has no criteria to be intubated, gives hope and keeps on the teams motivated to not throw up the towel. Because what I see, my fear is that people throw the towel or give up too soon. And that's what I'm motivating the teams that I'm training in my hospital, is that you don't need to give up.
Yes.
Unless you have a complete shortage of machines or masks, and then you have sometimes to give up. But until you have the technical options in front of you, the message is not to give up, right?
Not to give up globally, but also in each individual patient. I mean, if you're going, as they spend 15, 20 days on invasive mechanical ventilation, they are going to spend 10 days on continuous CPAP support. So you have to try to not to give up in the first time that the patient drops his SpO2, despite you are doing everything. You have to perseverate in the treatment. I mean, for these days, one of the best mottos that we can have is that one by Shackleton: by endurance we conquer. So that may be a message.
Yes, and this is a message that should be very clear, especially for doctors that are not pulmonologists. I mean, for internal medicine doctors and other doctors that are treating these patients, that you're going there and put some CPAP and oxygen and train the nurses. And the message is, first, you have to give them some anti-inflammatory treatment. And two, you have to be patient. I mean, Some doctors will tell you if in 3 days the patient is not, we can take out the CPAP, maybe it's time to limit the effort, and it's wrong, because we have seen patients after 5 continuous days with CPAP that made it, they evolved good. So it's a very clear message that we have to be patient, and we have to insist on this patient and not give up.
So I'm not sure if you have more questions, Miguel and Susana. If not, I think we can close now. Me, Susana, and Miguel, we're going to meet together to produce some slides for the take-home messages. And so I invite you, Anna and Javier, to come to the web link and try to see, because there is one slide that we're going to dedicate to you, because we are really, really very thankful to your efforts, and in these terrible times that you are living, to have the time to talk with us. So I'm really, really thank you so much for your time, and I hope that you can overcome these bad times very soon. And I wish we can be together in Madrid or in Porto and have to share a good glass of wine together and hug ourselves and be as always in the ordinary way. Thank you so much, Anna. Thank you so much, Javier.
Thank you.
Thank you, João.
So now, after the amazing presentation by Dr. Javier Sayas, the panel, me, Miguel Gonçalves, and Susana Moreira would like to address to you and give you some take-home messages. And I will start to share my desktop to make a summary of these take-home messages. And I would say that we would suggest 7 vital lessons that we have learned. First, organize and start training your staff and multidisciplinary teams as soon as possible. This is very important. You should also protect your staff as much as you can. Keep respiratory therapies as simple as possible and try your patient to cooperate. It can be very helpful by proning himself, by self-positioning. Do not give up early on CPAP, because there are some patients that are really improving and stabilizing on CPAP for more than 5 days. However, you should be very sensitive to the patient self-inflicted lung injury. So to avoid patients to have this increase in self-inflicted lung injury, you could also do some sedation. Dr. Sayas proposed to us a little bit of morphine. Also, it's very important that you interact actively with your critical care teams and ensure an efficient flow to step up and prepare for step down. And with this, you can accelerate ICU bed rotation and can increase the admission to the ICU for the young and the patients that can benefit most from invasive ventilation. Because the increase of hospital use, there is going to be a big burden on your oxygen supply. So you have to be very careful, because your oxygen expenditure will increase by more than 400%. And do not forget to treat and target the cytokine storm. There are some immunotherapy that you can do, some anti-interleukin, but this has to be shown in randomized trials, but still you have to target the cytokine storm. And so I think the messages that from New York we heard about the governor, that Andrew Cuomo is saying that the New Yorkers are very tough and the New Yorkers are people that struggle very hard, I think we can also say the same by our friends from Madrid. So thank you very much, healthcare workers from Madrid. We really love you. We love Madrid. And I think that the healthcare workers should not be forgotten. We know that every healthcare worker has the right for the best personal protective equipment. If they get sick, it's bad for everyone. And as you know, in Italy, we heard about very, very sad stories about medical doctors that lost their lives. So they had really their lives on the line. And this is the pictures of 11 of these doctors. And we know that they are more than 45 medical doctors that died due to the COVID-19. So Spain is also a huge number of infected doctors, and Portugal is also having infected healthcare workers. And we have the incredible task to protect these people. They should not be combating without an armor. So we should not send our troops without an armor. So prioritize the protection of your medical staff, your nursing staff, and everybody. So be safe, and with that we will win this war. Thank you for your attention.
So also I'd like to thank the opportunity to participate. This is a fantastic way to share knowledge. I think Portugal is being fantastic in sharing knowledge between hospitals. We are not we are like a big hospital as a country where each hospital is a different unit. I think all specialities, intensive care, pulmonology, internal medicine, nursing, physiotherapy, and other kinds of healthcare professionals are united against a common enemy that is COVID-19, and only sharing experience and only giving the example is we can replicate the good results and try to avoid the bad results. And for last but not least, not only we should protect ourselves, we should protect our patients, but also the more fragile patients, the chronic patients that are at home. They are frightened, they look at the news and they are afraid to get this virus. Try to isolate them as better as possible. These are the ones that are more fragile, and in the chaotic situation, they will be the ones that will suffer the most. Thank you once again, and keep strong and keep healthy.
Good night, all. It was a pleasure to hear from Spain and to have our question answered. But what I wish the most is that everyone have a safe journey in this war, and they keep safe, the family safe, and we do the best we can for our patients, keeping ourselves safe. Good night.